Guys, welcome to today's live session. We're going to be talking all about fake sciatica this week. It's a topic that we've discussed in the past, and hopefully revisiting it today will be helpful for many of you that are struggling with that all too familiar sciatic nerve pain that goes from the buttocks down the leg. This is particularly one for those of you guys that have been struggling with the sciatic pain without any lower back pain. And often this is one of the reasons you guys fall into that trap of the piriformis syndrome, that diagnosis, or rather should I say misdiagnosis, that leads you guys into doing the wrong things over and over and over again for many months, if not longer. And hopefully a little chat about piriformis syndrome today and about why it could be considered fake sciatica and what you need to do to help fix it in the long term. That's going to be a helpful one for many of you guys to perhaps change the way in which we viewed things, and as a result be able to get actual resolution to this problem. Because for all too many, we start out with maybe some history of back issues. When you speak often to the individual that's struggling with piriformis syndrome, they've got some element of history of back issues to some degree, right? There's a bit of stiffness, discomfort, aching. Maybe they've had a couple of episodes of back pain in the past. But often those that fall into this particular trap are those that don't tend to have any back symptoms per se. It is very much confined to the buttocks and then going down the leg. And the hypothesis here that people often fall into is really down to a anatomical anatomy quirk that some people will have. And you have to ask the question, if you've been struggling with piriformis syndrome and it's been hypothesized, have you been screened for this? And I'm not saying that you need to do that, but it starts to create a snowball of questioning the diagnosis, so to speak, of piriformis syndrome. Because the anatomical defect that we have here, or not defect, it's just a variation, it's normal variations within populations, is that as the sciatic nerve becomes the sciatic nerve by being conjoined with the different nerve roots that go up to make it, somewhere here in the pelvis, the sciatic nerve leaves the pelvis, goes down the back of the leg, and in most cases it passes the piriformis. In some of your cases watching this, it will partially pierce or entirely pierce the piriformis. And so the idea here might be perhaps, and I don't believe this personally, but I'm trying to get on board with why some might suggest that because your sciatic nerve pierces the piriformis, your piriformis is in spasm, and that's what's causing symptoms to go down the leg. I think that's generally the reasoning behind this diagnosis. But we're left with a fundamental question in that sort of scenario. And by the way, guys, if you've got any questions, comments, thoughts about your sciatica or ways you've been struggling with your herniated disc, you can always post those down in the comment section below. If we are one of the individuals that's been struggling with piriformis syndrome, we've been struggling with that sciatic pain going down the leg, and we've got an absence of lower back issues, we have to ask the question, well, how did I injure my piriformis? This one of many small muscles, lateral rotators of the hip, that's in here, deep in here, that's overlaid by the very powerful glutes, the glute musculature, glute max, medius, etc. And so how on earth did you manage to specifically injure the piriformis syndrome, the piriformis muscle, sorry, if that's what we're saying? And furthermore, let's suppose we have a case history, and it's very difficult to start to think about this, right? Because if we're suggesting that the piriformis has somehow become dysfunctional, we have to have some kind of causative factor. For example, if I have an issue with my bicep, maybe my bicep has rolled up my arm because I've torn my biceps tendon, there was an offending level of significant trauma that caused the damage to this muscle. Muscles don't randomly just start tightening up for no apparent reason. The second question is, if we are suggesting that the piriformis going into the degree of spastic contraction, tightening, dysfunction, is sufficient enough to squeeze the sciatic nerve and result in symptoms down our leg, well, firstly, why when we stretch the sciatic nerve using that classic piriformis stretch, figure 4 stretch, right? Why doesn't that immediately cause sciatic symptoms down the leg? Why any time we have engaged our piriformis musculature and squeezed it as we've been walking around our daily life for our entire time on this planet, why haven't we been plagued with constant spastic contractions and symptoms going down the leg? Sorry, I misspoke there. Normal contractions of the piriformis, right? If we're suggesting that squeezing, are you real or just a video? I hope I'm real. I think I'm real, right? If we're suggesting that just squeezing on the sciatic nerve, the normal contraction of a muscle would cause sciatic symptoms down our leg, wouldn't we be finding that we're experiencing this all the time? And it starts to become more and more preposterous the more and more you talk about it. Now, what we often find, to the contrary, is if we take a step back and look at back injuries, sciatica, and look at, okay, well, what causes sciatica? Symptoms that go from the buttock down the leg, right? It is, where can these actually be caught out? Because nerves run past muscles all throughout the body. They run in close proximity. They don't run in vacuums where they're not touching anything. And so where can it get caught? Well, there are some design issues, most notably in the lumbar spine, the spine in general. Here is one of the very few locations where we have a bony hole which tissues run through, vascular tissue runs through. And guys, keep the comments coming in. I will get to those very shortly. I'll just finish this thought for those of you struggling with piriformis syndrome or sciatica. This is one of the few locations in the body where we actually have a bony tube. In most other areas, nerves and tissues run between muscles. They run between muscles and other soft tissues, etc. So there's a degree of stretchiness to this, but not in the lower back. And so by and large, we have these injuries to the lumbar spine, the herniated discs, etc. Insert your diagnosis of a lower back injury here. And that is what irritates the roots. Well, we're all perfectly reasonable, or we perfectly reasonably understand that with a lower back injury, we can get inappropriate functioning or dysfunction of the glute musculature. Why? Because it's controlled by this section of the lower back. We can all get dysfunction of the hamstrings. The hamstrings tighten up. Why? Because we have dysfunction of the lower back, and those nerves can send inappropriate signals to the hamstrings. The same for the calves. And then we've got the sensory component, right, where we actually experience the pain. We might experience pain in the big toe, numbness, tingling. We might experience pain in the shin, right, on the outside of the shin here. Some people say terrible burning, like a copper wire in the shin. Others just down the back of the leg or slightly out to the side. It's very clear that in all of those sorts of scenarios, we can get on board with the idea that it is actually a lower back injury that is irritating the nerve roots here, giving rise to those symptoms and dysfunctions. In the muscles, it's a dysfunction of the muscles. In the sensory component, it's feeling altered things, abnormal things. So why do we take piriformis as one random muscle that we all of a sudden say, well, no, that one has decided to contract on its own in and out of the ordinary way, and so that is what is giving our symptoms? It makes no sense. What is much more reasonable is, just like all of the other muscles, particularly in the buttocks and the hamstrings, the piriformis is controlled by the sections of the spine, or the nerves that leave this section of the spine. And so we have at its root cause a lower back injury that may well be giving rise to some degree of inappropriate contraction of the piriformis muscle specifically, but also the glutes and also perhaps the hamstrings as well. And that is what is giving rise. When you irritate and move in one way or another, it's not your tight piriformis, although that may be contributing to the problem. It is the injury at this level that is being violated, that is being strained, that is giving rise to your symptoms down the leg. And then what happens when you experience pain? What do? We wince. And what happens when you wince? Things get tight. Is that unreasonable? Is that to suggest that the tightness came before the injury? Or that the injury triggered the tightness, triggered the muscle reaction, triggered you to go, oh, that hurts, or oh, that hurts. When you go, oh, that hurts, even your jaw tightens up. Are we now suggesting that the jaw is contributing to the sciatica? No, of course not. And so, guys, I will get onto the solution very shortly, but it's just to help you guys really think about this a little bit more clearly, so we have understanding of what we can actually do to get better. But that needs to be preceded by an understanding of what the actual problem is and what it's not, so we don't go through the next bit that I'll talk about. And that is falsely assuming that the sciatic symptoms are actually caused by this piriformis muscle. And so what we have is an injury to the lower back that is falsely being diagnosed as some random contraction of the piriformis. Hi, Tina from Australia. And guys, I see the comments. We will be getting to those, right, very shortly. We've got plenty of time, so don't worry, right? But buckle in for the piriformis, right? And so we've got an injury to the lower back. We've got this piriformis. And for many of you guys, as I said at the start of today's live, you go for maybe weeks, maybe months, and sometimes years trying to just hammer this poor little piriformis. And when you're hammering the poor little piriformis, you've all seen it, right? The physio, the osteo, they've got the elbow, they're digging in there, right? You've done this for 15 to 20 sessions and it's not doing anything. Then you go home and you sit on a cricket ball or a softball and you massage the buttocks even more, right? Then you do whatever else, right? Insert extra stuff here. We are dealing with a injury to the lower back that is leading to dysfunction. That means these guys here, the buttocks musculature, which would include the glutes because they're over the top of the piriformis, right? this musculature is dysfunctional, meaning it doesn't function as well as it should. So then we're basically tenderizing the muscle over repetitive sessions, creating more tissue damage, because the mechanism of action for those kind of elbow in the buttocks treatments is that you create a bit of minor tissue damage that the body recovers from and everything goes hunky-dory. But that's not the issue here. You're basically causing repetitive tissue damage to this area. And if you want a better description, later this afternoon, when you're having your meal, if you're having, go have some steak or some chicken, put it on the kitchen countertop and dig your elbow into it and then look at it and go, does that look better or worse, right? It's a bit of a tongue-in-cheek argument, but you start to see how, and these treatments are painful. You know, when someone's digging their elbow into your buttocks to release the piriformis, it's causing pain because it's causing more damage to a muscle that is not the primary issue. So what I do believe in some cases where you have this chronic mistreatment of the buttocks is that you're actually causing a degree of tissue damage in that area, right? Not least of all the glutes that you're having to go through. You're just hammering through those glutes for successive sessions, not knowing that the glutes are actually maybe partially dysfunctional as well because of what's going on in the lower back. And therefore, if they are dysfunctional, their ability to go through the healing process, maybe we could call that into question a little bit. Then so that's the first issue, maybe causing actual local tissue damage with the treatments that we choose to do, typically for piriformis syndrome. Then we talk about the secondary issue, which is you're not actually identifying that the back is an issue. So you're continuing to do things with no care or attention for the lower back. And so you're continuing to bend and twist and because it's my piriformis, so my back's fine. I can bend all over the place because the physio said it, or the osteo said, or the chiro said, it's not my back. There's nothing wrong with my back, so I can carry on bending and twisting. So we're continuing to make the problem worse. And then what's more is that when we are doing some of the specific piriformis stretches, like we're like this, and we're hugging and doing the piriformis, we're rounding our lower back further, creating more issues. So it's kind of a three-pronged way. We arguably, with the treatments that we choose, the cricket balls into the buttocks, aggressively trying to massage out this area over and over again, we might be creating actually a degree of local tissue damage. Secondarily, we're just ignoring the lower back, so allow it to get worse. And thirdly, we might actually be doing some stretches that actually make the back worse, objectively speaking, because it's all going to come down to this section in the lower lumbar spine. That's where the actual issues are. So hopefully that makes a little bit of sense to you guys as to why this is a misdiagnosis, why we need to stop chasing piriformis, why we need to start focusing a little bit more on the actual injury at its root cause, so we can start to move forwards in a more productive manner and resolve the issue that we have, which is the thing that's causing us pain, right? It is the lower back issue that is causing us that sciatic symptoms or those sciatic symptoms down the leg. I'm just gonna have a look at some of the comments here. SP says, I love pushing on my glutes medius. It's so relieving. Fantastic, fantastic. If that feels nice, great. But we've still got to work on the actual injury itself, right? We've still got to work on that. Mason's talking about directional preferences. That's cool. There are lots of directional preferences. What that means for the actual injury is not really, it's cool, right? A lot of that is it comes down to the McKenzie stuff where they're talking about, oh, find the directional preference and do this, that, the other. That's not rehab. That's not rehab. You're just getting into a funny position that feels nice. That's not rehabilitation work, in my opinion. I know others will disagree. That's fine. I understand that. Titanium says, I have an L3 to S1 fused on the 12th December because I let it go for 20 years. Hopefully you're doing better, Titanium. Hopefully you're doing better. Someone's been recommended an L4-5 fusion, an L5-S1, modic changes, L5 on DDD on both levels. One of the important things to understand about surgery, fusion is maybe has an extra layer of complexity to it, but the most common surgery that you guys are going to have or be exposed to or be suggested is going to be the microdiscectomies, right? The minimally invasive stuff to, just get rid of a bit of the disc here, right? And so in those sorts of scenarios, the most important thing you can understand when you have the surgical intervention is that you are not fixing the problem, right? You're removing a bit of material that's in the wrong place. That's not the injury. The injury is the injury to the segment itself, the annulus fibrosus that has allowed that bit of disc to migrate outside of its normal boundaries, so to speak, right? It might be that they're doing something like a laminectomy or they're shaving off bits of bone in certain places. Again, that's not the injury. The injury is the injury to the segment, and the surgery is clearing up some of those things. Now, in some scenarios, we might have some kind of fusions, and the hypothesis there is that the stability of this is so bad and we don't give you any hope, and so we're going to stabilize it for you. But in doing so, we have a significant amount of tissue disruption. We also have a change to the architecture. And so in all of these scenarios, there is no one of those scenarios where the ability to learn how to, or the need to learn how to stabilize and protect this area is not present. If you're going to have no surgery at all, and you're going to continue on the non-surgical route, which, by the way, is the appropriate for the vast majority of individuals with lower back issues, right? You do not need surgery. Obviously, if you've got that discussion with your surgeon, they've got extra information, so you have to take that on board, right? But the vast majority don't require. In those scenarios, stabilizing this area to provide protection, and then rehabilitating the ability of the spine to bear load. Right? That it's got to be goal orientated. It's not to feel better. That is a consequence. Rebuilding the resilience, the structural resilience of the spine, is what we are looking to do. In the scenario where you have a minor surgery, well, fantastic. That's maybe removed some of the worrying things, right? But we still have to do exactly the same stuff and provide stability to the spine. The costs are maybe a bit greater, perhaps, because if we get it wrong, we've just had surgery, we've had some disruption to the area. Okay, something to consider. In the scenario where we've had the fusion, and they've gone, just, you know what, we're going to fuse it for you so it doesn't move anymore. Well, in that scenario, it's even more important because you now have fewer joints in the spine that move. And so you need to be able to protect this region even more so. And so the costs, the need to do the stabilization work is present in all of these spectrums. It's just the degree to which it's important and the degree to which you need to adhere to it becomes ever greater as we increase the degree to which we are getting involved from a surgical standpoint, in my opinion. Got some more comments of people, right? And guys, take note of this, right? I'm going to read through a couple of comments that are being had here, right? L5S or moderate degenerative disc disease. How do I maintain the degeneration? I have L4-5 and L5S1 paracentral disc protrusion, right? I have slight bulging disc at L4-5. Is there any way to actually recover? Yes, is the answer to that. I've had 2 microdiscectomies and 2 spinal fusions in the last 5 years. I assume the similar sort of level, right? Jesse, I've had a bulging disc at L4-5, right? All of you guys, it's the same thing. I come on these lives every single week. Understand that most of you struggling with lower back pain, there's a reason I talk about these numbers, and people say, well, yeah, what about me? Most of your lower back issues, your sciatica, are generated from these last 2 segments of the lumbar spine. It's L4-5 and L5S1, and there's reasons for that, which we'll go into often. I'll see if I get around to it today, but just looking through some more of the comments here. I understand, you guys are all experiencing the same root cause injury. Now, if we then polled all of you guys that have commented, right? We've got Jesse, we've got Marina, we've got a couple of others, right? Posting on here. I'm not reading all the names, Titanium, etc. Right? Josh, Green, right? If we then polled you guys on what all of your symptoms are, they're all different. And so if you guys are all trying to chase your symptoms, as differing as they may be, is that what some of you guys might find sitting's better. Some of you guys might find standing's better. Some of you guys might find you can bend one way. Some of you guys might find, and you've all got the same injury. This is why this comment that we had earlier on about directional preference. No. Focus on the injury, not the symptoms. As long as we don't have the presence of emergency red flag symptoms, then we carry on with the rehab. We understand it's a lower back issue. It's primarily going to be focused at this area. What do we need to do? We've lost the integrity of these structures. They have been damaged. We need to provide support. And the best way we can do that is through the musculature, because it can activate immediately. We need to learn how to do it. So there might be a learning curve, but we can offset the inherent weakness at these injured segments for a period of time while it goes through a healing process by providing more support for this region through the midsection. And that's not just about strengthening the core, because you're not strengthening the core to start with. You're learning to utilize the core. You're learning to actually move correctly. You're learning to actually provide some degree of control from here. You're learning to separate out the movement of the hip from the spine, because too many of you struggle tremendously. Anytime you go to bend, you just round the lower back. You bend the hip and the back, right? You don't know how to actually bend from the hip only so the back stays still. These are skills, right? I just jump up and do it. But when we see members in the program learning how to do this, which is why we get the videos on, right? There's this process of, okay, they stand up and then they go, okay, right, okay, right, and that's it, right? And I'm not saying that in any way, shape, or form to be disparaging. I'm saying it to be real. If you have to think that much about how to perform a hip hinge, that's great. Because a lot of you guys have been struggling, thinking, I don't know why I need surgery. I don't know why, maybe that's an option of consideration. I don't know why I need these injections. I keep on struggling to get better. It can't just be me. Maybe there's something wrong with me. And you can't even move correctly. Well, the great news is there's no surgery for that. It's learning. It's a skill. You can develop it. But if no one has suggested that it would be important, of value, then you haven't done it. And so it's a simple stone that just needed to be turned over. And it would have been great if we turned that stone over and learned that skill 6 months or 6 years ago. But we can do it now. And that's the important point. So we've got some other comments. How bad is kyphosis? Agon says, how bad is kyphosis? Kyphosis is a statement of a forward bending curve, so it is perfectly normal in a human being. All human beings have a kyphosis in the thoracic spine, which is the rib cage, where the rib cage is, and a kyphosis in the sacrum. Okay, we don't really talk about the sacrum too much because that's a fused bone; it's not going to move, right? But we then also have lordosis, which is a backward bending curve in the lumbar spine, or should have, and in the neck, should have. 1 second, we might be sneezing. No, maybe not. Okay, so hopefully that's helpful. SP says, doing leg extensions and leg press triggers my sciatica. Yes, most likely because it's leaking into your lower back. So if you've got a issue in the lower back and it's sending signals down your hamstrings will be limited. So as you do the leg extensions, your back is rounding. If no one's talked to you about this, which is so often the case, for example, for SP, who's posted on TikTok, if no one's ever talked to you about what's actually going on, if you said you've got sciatica, just go on stretch or something like that, then you don't understand that you should actually try and maintain a neutral spine if you're doing leg extensions. If you're doing leg press, as soon as the weight comes down on you, your back rounds and you hammer through the lower lumbar spine down here, and that's going to aggravate symptoms, right? For some of you guys, it might feel nice. The point is, it doesn't make sense if you've got a lower back injury. And if you're never communicated this, then you continue to go blind. You don't know that things need to be done in a smarter way. Marina says, I have sciatica without a clear nerve compression. How is that possible? Very possible and very, very common. The amount of times we get people who have sciatic symptoms, they go and get their MRI and they say, oh, look, you've got a disc bulge, but it's not pressing on the nerve. So we don't know, it's not sciatica or something like that, right? They're forgetting that when you have a disc bulge, you have damage to the ligaments. When you have damage to a tissue, I'll get to the Pilates question in a second, Jesse. When you get damage to a tissue, you're going to get inflammation. When you get inflammation in a tiny hole here, the disc doesn't need to be pressing the nerve, but a large amount of inflammation building up in this area can irritate that nerve and give rise to the sciatic symptoms. So it's fantastic that you don't have a severe disc bulge, but you still have an injury, and it's perfectly reasonable that it generates your sciatic symptoms. So let's get started working on the actual rehab. And Mason says, are you a fan of Stuart McGill? I think a lot of the stuff that he talks about crosses over quite nicely. But I think, unfortunately, I was speaking to someone the other day who'd actually done the work with Stuart McGill specifically before joining the program. And I think then, you've got the McGill Big Three, okay? There are comments about that, but generally there's a lot of alignment in that scenario, or in between what we talk about, the neutral spine, etc., and what he does. But there's no progression. There's no progression. It's not really a program. Just doing 3 exercises without clear progression. I was speaking to the person. I said, well, what were you doing when you saw them? About 6 months ago, when you saw Stuart McGill. And he said, I was doing this, it was 6 reps, 5 reps, 4 reps, 3 reps, 2 reps, or something like that. I said, what are you doing now? Or before you joined the program? He said, I'm doing the same. It's a bit easier. I said, okay, well, that's not rehab. You've just done the same thing for the last 6 months. You could do 6 months ago. You just do it a little bit easier now. You haven't driven progress. Then I think of someone else off the top of my head in the program, and we think of someone who joined the program, I think it was just before Christmas time, with raging sciatica, couldn't do anything, and now is hip hinging with 80 kilos for 10 reps. That is progress, irrefutable progress. Now, it needs to be objective. We need to have some measure marker for actual improvement. And there needs to be a goal. The goal that we talk about in the rehabilitation is improving, is rehabilitating the spine's function and its capacity to bear load. That's what we need to rehabilitate, because it is bearing of load and moving that creates the problems for a lot of you guys. It's when you were bearing load that it hurt. It's when you were bearing load sitting down with increased load that it hurt. It's when you were bearing load carrying something that it hurt. It's when you were bearing load and moving in one direction or another that it hurt. Why? Because you didn't stabilize these joints and they are currently injured. Does that mean you can never bend your spine again in the future? No, it does not, right? You can bend the spine. You will notice that I bend my spine in all different directions, right? You can do that. But when you have an injured joint, you can't. Well, you can, it'll hurt, right? So stop doing it. Stabilize it, provide some protection so it can go through a healing and recovery process, and you can support that process. What else have we got here? Marina said, thank you. I wish doctors spoke to me like that. I don't know which bit I said, Marina. There's comments coming in pretty quick, so hopefully it's helpful. LC17 says, would this show up on X-ray? I'm not sure what we're talking about there, I'm afraid. Shan says, I have spondylolisthesis at L5S1 and DDD on the disc in between. What exercises should I avoid in the gym? You should be doing rehabilitation work, right? And just to understand, spondylolisthesis specifically is when one vertebra slips forward. So in Shan's case, it's where the L5, which is this last green one, slides forward on the S1 vertebra, the sacrum, right? And it slides forwards. It might be grade 1, grade 2, I don't know. Generally, it's graded 1 to 4. And so in that scenario, patients often get very confused because they see one person and they say, oh, well, you've got a spondylolisthesis at L5S1. And then they see someone else who says, well, you've got stenosis at L5S1. And they see someone else that says you've got degenerative disc at L5S1. And someone else says you've got degenerative and you've got some facet joint. And they think it's they're saying different things. Right? And then their patient goes, well, I went to one practitioner and they said I had a spondylolisthesis. I went to someone else and they say I had a disc herniation, right? Oh, no, it's the facet joint that's causing you pain. No. It's the segment. And now you've got a nice colorful picture of what is going on. Spondylolisthesis are a fantastic, it's not good, but it's a fantastic example of back injuries in so much that it really displays the involvement of everything very clearly in many cases on the MRI imaging of all of the factors, because that's what you have, right? You've injured the segment of the spine because you can't really strain the disc without having some degree of strain inappropriately testing the ligaments that run between the spine on the back, and also the capsule of the facet joint, which is also ligamentous, right? Yaz says, how do I join your program? Send us a DM. We'll just send you a link directly. But you could go to the website, backinshapeprogram.com, and then sign up from there. But that's the link I'll send you, right? So yeah, just send us a DM if you're over on TikTok. Guys, just coming over to YouTube to have a look. Mike, can you tell me how long I should do the towel decompression, please? Towel decompression should generally be done for anywhere from 3 to 5 minutes, Carolyn. It is in the tutorial videos in the program, right? And so very, very important stretch to decompress the spine. Now, I would generally suggest you do not do it for longer than 5 minutes. More frequent periods, perfectly fine, but not longer. What else have we got here? My sciatica is located in my left glute. Sitting bone, driving mad. Yeah. People have the sciatic pain or the referral from their lower back injury in different areas of the back, different areas of the lower body, different areas of the leg, etc. Harsh says, my back injury happened 3 to 4 months ago. After that, it got better with stretches, but recently after a flare-up, my light hip pain is very hard to bend down. Am I done for? No, but you need to do the rehabilitation work. Too often people go on how they feel as a measure of their improvement. While that is nice and that is the main focus, right? The reason you are motivated to do something about your back pain, your back injury, because you had pain, right? You see this all the time with adherence to rehabilitation work once symptoms go down. And this is a perfect example, right? The body is actually healing every single day. And if you are managing to just get out of the way of that, or just rest or whatever, things will actually settle down, right? Given time. And once we get to a chronic point, then maybe there's a little bit of extra layer of complexity, but it will settle down. But if you're not rehabilitating the strength and resilience of the lumbar spine, in the process of things settling down, everything else gets weaker. And so you get more vulnerable, and then you re-injure it again and again and again. You need to focus on rebuilding strength and stability in your spine. That is the ticket, right? And that process will not be finished when you are pain-free. When you are pain-free and when you're doing the things you want to do, you still need to continue that process. It is a long-term thing. Ethan says, it seems like every expert says do something different. I try them all and nothing helps. If you try them all, you're going to tie yourself in knots, because if you're listening to us talking about keeping the spine still, and then you're going and doing something else that's talking about bending the spine, you can't do both of those things at the same time, because to do one, you're violating the other. And that's not going to work, right? It's not going to work. So you have to pick someone that explains things and hopefully make sense, right? And then the other thing of expectation is over what time frame, right? So often people, like when someone says, oh, well, I tried one treatment, a couple of treatments with physio, tried a couple of exercises here, tried a couple of stretches there. I said, how long were you doing these for? Oh, I was doing them for this long or that long, whatever it may be. And often you're not actually doing them properly, right? Because to know if it worked or not, you have to actually go through the entire process. You can't just stop partway through, because especially when it comes to actual rehabilitation work and strengthening work, much of the early stages, you're just learning how to actually perform it correctly. So someone like Ethan might start doing the rehabilitation. He starts playing around with squats, hip hinges, etc. And like, you're still having flare-ups. Well, of course you are, because you're not actually good at them yet. You have to get good at them, right? And in getting good at them technically in a safe environment, that invariably involves some degree of error. And so you watch tutorials, you learn how to do these things in order to minimize the unnecessary errors in the process of learning the thing, right? It would be so much better if we just started out the process before we actually injured our back. Right? Rosen says, please help, I've got 2 bulging degenerative discs Exactly what we're talking about here, Rosie, is very relevant to you, right? Very relevant to you. When we say nothing helps, right? Or nothing's working. In order to actually start to protect this area, you have to acknowledge that there is weakness and vulnerability. You have to acknowledge there's an injury. Well, many of you guys have done that already, right? Which is great. Now, we need to protect this area. And therein lies the first test, right? Can you perform the exercises that we talk about all the time? The dead bug, the marching bridge, the squat, the hip hinge, the step up, the single leg twitch. Can you perform those? Right? Can you perform those effectively with good form and coordination? And the answer often is no, not to a satisfactory level. You can perform a version of them, but no. And then that's great. That means you've got something to work on. But until you can perform those well, you're going to be struggling. LCDA said, I had fake sciatica because of QL tightness that caused piriformis irritation. I don't buy that. I'm sorry. I hope you're better. But to suggest that QL randomly became tight on one side for no apparent reason, and that it was just QL, it wasn't the other erector spinae muscles, and that somehow caused the piriformis to become tight for no apparent reason as well. These things are very big stretches, right? It's very difficult to really justify and dig into that actually being the issue. What most likely happened is that you had an injury to your lower back that led to muscular spasm in the QL and maybe the piriformis as well, because you've got an antalgic posture. And it wouldn't just be the piriformis, it's probably going to involve the glutes as well. That's generally what happened. And then hopefully you got better. Hopefully you're doing well, which is fantastic. That's all that matters, right, at the end of the day. But yes, there is a lot of disagreement or seeming disagreement about what you should do if you have these lower back injuries. And the important thing is not just to say what to do, right? A lot of you guys jump in here, and this is, maybe this is for you guys to think about your end, right? A lot of you jump in and go, what do I do for this? What do I do for this? What do I do for this, right? But you don't want to hear the explanation. So you get confused because someone says one thing and someone says the other. But it's the explanation and the education that actually helps you guys understand what you should be doing and why. Because if you've got an injury, explain how wiggling an injury gets it better. It doesn't. It doesn't. Wiggling an injury, bending, twisting, or doing the other repeated movements does not mechanistically build strength and resilience in tissues. It's very, very hard. Someone says makes it worse, right? Yeah. It's not a mechanism for build. Otherwise, you just see bodybuilders in the gym constantly bending and twisting, right? No, you in order to build strength and resilience back into tissues, you have to expose them to the right kind of strain in a way that you can do progressively over time in an increasing manner, right? And that, how do you do that with a cobra? How do you do that with hugging your knees? How are you able to actually know? Again, this comes into other issues with the lower back. How do you know how much movement went through your L5S1 when you did that movement? You don't. You don't know. The only thing you can, I would argue, reliably keep track of as a metric to improve your rehabilitation is the load that it's capable of bearing. And you know that in the process of bearing that load, you are challenging the tissues that bear load, right? And you knew that you couldn't bear the load of picking up your toddler or carrying out the garbage or whatever it may be, right? But now you can as you make progress through the rehabilitation. So the load, the ability to hold, a water bottle and perform a squat. Like, it's reasonably obvious that if I'm holding this and I squat and then hold something heavier, the only thing that's really changed, as long as I've got good technique, is the amount of load my spine is having to bear. So I can create some kind of pathway to improve the strength and resilience. If I'm just holding it for 2 minutes or 1 minute in those funny positions that some of you guys see, it's very difficult to make reasonable progression. Because one thing is very clear outside of the back space is how to actually build strength and stability. Right? Building strength in muscular tissue, which is what you're doing in the short to medium term with your rehab, is very, very clear how to do that. And it's not holding a position for 20 minutes or 2 minutes or 3 minutes or 30 seconds. It's sets and reps. And it sets and reps to an appropriate intensity, right? But you need to obviously be safe first. Like, this is very, very clear. Or a lot of the obfuscation of like understanding with lower back issues, people saying, oh, we saw some research that said exercise does this, and then we saw some research that said exercise didn't do that, and then this shows that exercise, and you leave patients being very, very confused. But what are we trying to achieve in our rehabilitation? We're trying to improve the strength and resilience of this area, right? And so how do we go about doing that? Well, we work first in the muscles. How do we strengthen the muscles? Very, very easy, right? We strengthen the muscles. It's very, very well researched. There are different ways to do it. There are some ways, I would argue, that are intrinsically a little bit simpler, but it all comes down to exposing the tissues to some kind of strain that is measurable so that you can actually periodically and incrementally increase that load over time. It's just that simple. And so find a way that's easier than just choosing, for example, the squat and the hip hinge and just going up the weights. Carefully, of course, aggravation free, of course. These are all extra bits of consideration, let's say. Just having a look through some more of the comments. So let's give more likes at the top bar. Thanks, Awaken Nation. Appreciate that. Void Nitrous, I've practiced everything, but nothing helps in sciatica, and you can't do much to lose weight. Yeah, Void, have a look at what we're talking about, right? I've tried everything, but nothing helps sciatica. Right? Often that kind of verbiage is, I'm going to try something now to release my sciatica in 5 minutes time. That's not, you're working on the wrong time frames. I'm sorry. Void says nothing does any improvement except making doctors, physiotherapists, chiropractors rich at the expense of our pain. That's disingenuous. That's disingenuous. I know you might feel like that if you've been struggling and you haven't got help. But hopefully some of this stuff is helpful. And do you know how much you paid for it, Void? Nothing. Other than the internet connection and whatever you're watching this on, the device. Toonandy says, is walking best for sciatica? I have it for maybe 3 months, 3 weeks, 3 years, I don't know. Walking is not rehabilitating your sciatica. Walking can be helpful. Walking is a helpful tool, right? And Rosie, the same is true. Everything we've been talking about is relevant for a degenerative disc. Walking is helpful in so much that the problem that you have is twofold. You have an injury to the lumbar spine, right? We've got the herniated disc as an example, but it could be your degenerate disc, okay, Rosie, specifically. And that injury creates inflammation. So you've got the actual strain of straining the tissue in the moment, and ouch, it hurts. And then you often get this kind of residual issue, which is the inflammation filling these small holes where the nerves come out. Walking is helpful because providing it's not exceeding the tolerance of load bearing of your injured lumbar spine, so you do short durations, you manage the duration, right? Non-aggravating duration. That might just be 10 steps, by the way, right? It might be more. Walking helps manage the excess inflammation with little movements as you're walking. So it's helpful in that regard. But it is not rehabilitation. It is not strengthening things, generally speaking. What else have we got? Darren says, I have issues walking. I have to stop and rest after about 100 feet due to pain. So Darren will be making a mistake if he's walking 100 feet. He needs to figure out at what point is it still not aggravating? What's the greatest distance? Is it 75 feet? Maybe 75 feet is the right amount of distance that Darren can do without aggravation. So he takes note and he only walks 75 feet. So maybe he does like a 36 feet circuit, right? It sounds silly, but that's where you start. Too often people make the mistake of trying to do more out of frustration, thinking that if they just push through, everything's going to be okay. And there are times sometimes to push through, but by and large, you need to have an appreciation of your actual limits and operate within those. Otherwise, you're just reckless. And if you operate within those and start to make improvements or drive improvement, you will find that those limitations lift. So the ability to only walk 75 feet instead of 100, right? Because 100 causes pain, so 100's cut off, right? Which means it wasn't 100 because that's when you actually decided to stop. Symptoms must have started to onset earlier than that. So let's just say it's 75 feet. As you progress through the rehabilitation, you find you can walk for 120 feet before symptoms start to set on, and 150 before you have to sit down. So you do that as a test every so often. But you start to make progress by building resilience of the spine, which allows you to do the thing that you can't do. What else have we got here? Mine's spasming so bad, I feel like I'm a jolly jumper. You know, sometimes it can be tough. Ben says, what's your gold standard lower back pain exercises? We don't do lower back pain exercises because that's not a problem. You're not addressing a problem if you're doing lower back pain exercises. Although for the algorithm, some of the videos will talk about that. Hopefully in the course of the video, it explains that you are doing a lower back injury exercise, and the best or gold standard injury exercises to help you guys recover from your back pain, recover from your sciatic pain that is caused by an injury to the lumbar spine are the following: dead bug, marching bridge, squat, hip hinge, step up, and single leg hip hinge. All of these exercises, when done correctly, do not move your lumbar spine. The question you have to ask yourself is, what version of those exercises can I do and retain composure and control over my lumbar spine such that they do not cause aggravation? The answer to that might be quite pitiful. It might feel quite embarrassing. It might be that you can only squat holding onto your partner's hands like this, You can't properly consider doing a squat on a barbell. Goodness gracious me, that's way out of your league at the moment. Notice I said at the moment, not ever. Okay, but that gives you a starting point. Everyone can adjust these down to the appropriate level of competence that they have. And it's important that you don't try and cheat yourself, because you're only cheating yourself by doing a variation that you're not competent to do. And then those same exercises can be built back up, meaning you can progress onto a barbell, you can progress onto using dumbbells, you can progress on, and you need to, because that's what drives your improvement. Someone says, not even non-specific lower back pain. Non-specific lower back pain is a cop-out. You've got an injury, right? You've got an injury to the lower back. You do the same thing. We've had patients, members of the program. You guys can't post a diagnosis that's related to the lower. I mean, you might be able to post some other random diagnosis like a lung issue or something like that. You can't post a lower back diagnosis in the chat that we haven't had members come through the program with, or patients come through the program doing exactly the same thing and building and making progress with. The biggest question is about whether where you're starting from and whether you can make progress with it, right? That's a tactical and technical question. And the answer to that is everybody can, but some people need a bit more support than others. So you've got some people that can hear these messages, hear what I'm talking about on the live session, and go and do it themselves. They can source a couple of videos on YouTube freely available, and they can make some progress themselves. Other people, they need a little bit more help. They need to actually have a bit more instruction. That's why we've got the program, right? And then other people need that, and they need a bit more help than that still. But the question is, how much help do you need with the same goal, the same plan? And it varies from one individual to the next. And then you've got to have the other thing that needs to be superimposed on this is you can't lose weight while you're eating cake 3 times a day. I mean, hey, you can, but you know, you can game the system if you really, really, really want to and really, really try hard, but you can't. And the same thing with the lower back, right? You can't be doing one thing to heal the lower back and 15 other things for the next 16 hours of the day that are absolutely hammering the poor thing. There has to be some engagement with the reality that you live with your back every single day. You have a responsibility to look after it. And many of the things that you're doing are problematic. They need to be reevaluated. Many of those things you can make improvements to, but can't completely mitigate. Many of those activities, for example, those of you that have young kids, I'm talking about toddlers, infants, you know, it's tough. You can do things better, but you can't do things perfect. But better is better than what you're doing right now. And that's going to be a positive for your recovery process. But if you just go, just give me some exercises to do and that's it, you're not going to get better. You're going to struggle. You might get better in spite of that, but you're going to struggle. You have to be part of the process. That's why education is so important. And that's why it's always frustrating when people jump in and they go, oh, just tell me the exercise to do. It's like, no, that's not it. That's not the solution. What else have we got here? Some comments. Side note, I love your hair. What's left of it anyway. Karen says, I was doing the program last night, 5K, didn't hurt at the time, but really sore today. Have a look at what else you've done, Carolyn. What else have we done that day, right? One of the important things to bear in mind when we're using very light weights, and I mean that in an objective term, 5 kilos is not a heavy weight. And the reason I say that is just have a think, right? You finish doing your squats with 5 kilos, aggravation-free, controlled, right? Example, right? Well, let's demonstrate this very, very clearly, okay? So you finish, and Carolyn, by all means, upload some videos to the members area so we can have a look, right? So you got your 5 kilos. You finish doing your squats very carefully with 5 kilos, right? You've done your 5 sets of 10. You then put it on the floor. I would suggest like this, okay? Because I didn't have to bend down to do that. Some people sometimes will put it on the floor like this after doing the good squats, right? Anyway, we finish the squats with 5 kilos. We then know that the squats were only to here, but then I go and sit on the chair in the living room, perhaps. And now I've got much more than 5 kilos load through my lumbar spine. I'm then going to go and get undressed before I go to bed and do all of this kind of stuff, even in the best way possible. And then I'm going to, again, sit in bed, twist and roll into bed, right? There's a litany of things that we're going to do the rest of the day. Why not blame all of those extra things? Maybe it's a cumulative thing, right? Maybe it is that cumulatively, the rehab plus all of the other stuff was just pushing us a bit too much, right? Maybe that's a factor. Maybe that's what's going on. But I'd suggest we need to look at the other stuff an awful lot more, right? Because this is why we really have been drumming in lately to you guys. Those of you struggling with lower back issues, 20% of your body weight to 45% of your body weight extra is going through your lumbar spine when you are sitting down, depending on how well you're sitting. So even if you're 50 kilos, that's 10 kilos, right? So you finish doing a workout with control, poise, care, and attention to detail, and then you go and sit down and put double the load through your lumbar spine, right? Now it's different when we get up to something like, 45% of our load, 50% of our load, etc., and we're getting issues after the workout. We talk about those sorts of things, and there are explanations for that, right? Sometimes DOMS is a factor, delayed onset muscle soreness. It's limiting the hamstrings, it's not addressed properly, and then that irritates the lower back a little bit. That's a second order consequence to the negative of our workout. It's necessary. We need to manage things better. But we're often in the early stages of recovery. And by early, I mean objectively, right? Objectively, it's not a time thing. The early stages of recovery mean where are you on the track of progress, right? And yes, sometimes I think I do a disservice when I talk about the long-term targets, but I think they're worthy of having in mind. But certainly you should have 20% of your body weight, 45% of your body weight, and then for ladies, 75, and for men, 100% of your body weight. Those are the main kind of milestones. And if you're not even at the first milestone and you're still struggling, carry on. Look at everything else first. Of course, validate that we're doing correct technique, etc., etc. But much of your daily life is going to be so much more strenuous than the exercises when you're doing them carefully. And much of your daily life will be done in a way that is significantly more precarious than the exercises. And what's more, regularly we talk to people and we say, well, how do you feel during the day? Well, I have a bit of pain here and a bit of pain there. I'm still struggling a little bit. And you go, how do you feel during the exercise? Well, that's the only time I don't actually have aggravation. Do you know why? Because that's the only time you're focused on what you're doing. The rest of the time you're living life, you've got distractions, you've got other things to think about, other things to do. So it's perfectly understandable. It's perfectly reasonable. But as you make progress and build strength in your lower back, daily life becomes relatively a lot less strenuous. What's we got here in the comments? Guys, we are getting into the last 10, 12, 15 minutes or so. Hopefully this has been helpful for you guys. Those of you that posted comments, questions, etc., really do appreciate them. Keep them coming in as we get towards the end of the live, guys. I will continue to go through them, just looking through some of these. Monica, maybe. She's got stenosis at L5S1. She's probably got a 10 mil and 7 mil disc bulge at that level, and then 7 mil L4-5, how to help, everything that we've been talking about, right? Doing your dead bugs, your marching bridges, your squats, your hip hinges, your step ups, your single leg hip hinges, learning how to stabilize this area, Monica. If we've got multiple discs that have a degree of degenerative change or degree of bulging to them, which is one and the same fundamentally, we could say, you need to learn how to stabilize this section of the spine effectively with a neutral spine, not hugging the knees or anything like that. Kim says, what about the SIJ? Unless you're a pregnant lady, don't worry about your SIJ. It's generally, if you've got issues that you feel are coming from the SIJ, right? It's very, very practically difficult to delineate those from the lower back. Secondarily, the SIJ moves about 1 to 2 degrees in most adults. Again, pregnant ladies, it's a little bit different because of the process of pregnancy and the laxity that occurs in those ligaments. So there is more movement there. But by and large, the SIJs basically don't move, and they don't move in a way that's perceivable. I don't know about you, but can you really move your body by 1 degree or 2 degrees? Right? You can't even move your finger by 1 degree or 2 degrees. We can't, as human beings, move our sacroiliac joints. We, as human beings, can't move our lumbar spine segments, right? We can move them grossly. I can just bend one way or another. If I do this, right, my right SIJ is going to have some movement going through it, right? If I go through this range of motion, my SIJs are moving in some small way, but I cannot possibly hope to focus down to the SIJ. And so fundamentally, all you can do is stabilize the lumbopelvic region. And that's everything we've been talking to you guys about. People think they need specific stuff for the SIJ, right? You will probably notice that when you do exercises like the step up or the single leg hip hinge, that one side is better than the other, right? There's weaknesses, vulnerabilities, etc. on one side, which will of course have a factor. But generally speaking, I would suggest, again, apart from the pregnant ladies, that any observations of SIJ issues are going to run downstream of a lower back issue. Consequently, and generally speaking, the diagnosis will come from saying, well, we thought it was the lower back, but we tried doing rehab for the lower back, it hasn't worked, so it must be the SIJ. That's generally how conversations will frequently go. And I mean, how many people in the comments here have lower back issues that are not being dealt with properly? Right? That's what we see all the time, is lower back issues that have, bearing in mind, almost everyone that's ever come through the clinic and the program has seen other people before. So by definition, they've seen other people for their lower back and they haven't had help. 40% last time we polled had either surgery or injections. They've gone that far, right? And they still hadn't got what they were looking for. So it's worth bearing that in mind. Just looking through some more of the comments here. What have we got? 5 slips forward with opposing pressure from the coccyx. L5 slips forwards. So the coccyx won't have anything to do with the L5S1. But I'm just picking up some comments here from Amelia, who's posted here. The L5 we might be talking about spondylolisthesis will regularly refer pain down to the coccyx region, something that you see reasonably often, and people are looking for why. Well, how can I help my coccyx pain? And then you find out they've got issues at the lower back. It's very common for referrals to come down like this. Fundamentally, it's very difficult to actually do anything to strain the coccyx per se. Jasmine says L4-5 disc bulge or slip disc and nerve impingement. Classic diagnosis, right? What do we got here? We've got an injury to the segment L4-5 at this section of the lumbar spine. We need to stabilize that area, control it effectively, and then rebuild the stability. Zoe has had emergency surgery for cauda equina and not got much movement and still got pain. Hopefully the symptoms of cauda equina that led you to have the surgery have been resolved, and you can now focus on the rehabilitation work, right? Because remember, what they probably did, I don't know the details, Zoe, obviously, guys, I don't know Zoe's details, but let's hypothesize that she had some kind of disc herniation, or et cetera, right? Some description. And they have removed the bit that was hitting the cauda equina, giving rise to maybe the bladder and bowel symptoms. Right? We still got pain, yes, because we still got an injury. We've still got a poorly load-bearing structure, our spine, and it needs rehabilitation work. Unfortunately, in that environment where we have the emergency surgery, like with Zoe, we're probably not given the best outpatient care and guidance. Hey, look, we've averted the crisis. Now you're on your own. We need a little bit of help, right? Okay, Zoe said, unfortunately, she's still got bladder and bowel retention issues and leg weakness and numbness. It'd be interesting to know what they've said about that, Zoe. Either way, we've got to do something to restore strength and stability of the spine. Dirk says, can elbow pain with movement be linked to the spine? It feels like my mid spine specifically. Not really. You might get some issues over in this region if we've got an issue in the mid to lower section of the cervical spine, but not really. Oh, Zoe, that's not nice. Rehabilitation is what you need to do going forward. You've had the surgery, and if they're just leaving you at home, you've got to do something to build the strength back up in the spine, or around the spine, sorry. The good news is that we're trying to heal every single day, but these things have often been going on for a long period of time when we have these surgeries. Kyle says, had facet joint injections in my L4 and L5. Other alternatives to help the pain. So the injections generally are there to kind of numb the pain. I'll use an example. You're sat in the kitchen because you're cooking dinner, and all of a sudden you have this terrible pain in your ears. It's the alarm. The alarm is going off, the smoke alarm. So what do? Well, the injections are like taking the batteries out of the smoke alarm and then sitting there peacefully, expecting everything to be okay. Very soon, you are coughing and spluttering. Why? Because you didn't deal with the problem, so it got worse. You then look over to the stove, which we should have done in the first instance, to realize that things are burning and your food is on fire. Luckily, you've managed to catch it, so the house doesn't burn down. But you get the point. Injections are there to mask the pain. Now, sometimes they have a diagnostic value. They might be hypothesizing, and this would be communicated to Kyle, hopefully. It might not always, but maybe. We can hope. That they might be suggesting that they believe that the symptoms are primarily generated from your L4 or L5 facet joint. And so if they inject them and the pain goes away, happy days. If they inject them and the pain doesn't go away, well, good job we didn't do anything to them more seriously, because that wasn't the problem per se, right? But the reality is it's often a segmental issue. It's often a segmental issue. And just injecting one small part isn't going to solve the problem. And arguably, in the scenario where injecting into that area and you do eliminate the pain, I would argue there's cases to suggest that that's actually worse for you, because often it's only the pain that's stopping you making the problem worse. You're avoiding doing certain things like bending and picking things up because of the pain. So then the pain goes away and you carry on doing those things because we haven't been supported effectively as a patient with education, etc. Kim, go back up. We covered the SIJ a little while ago on today's live. Brick Hanser says, opinion on chiropractors for short-term pain relief. Guys, thanks for all the questions on TikTok. Good fun today. And YouTube as well. Chiropractor, right? The opinion on chiropractor is exactly the same as opinion on an osteopath, like myself, a physio, a GP, a plumber, an electrician, or whatever, right? You get good and bad in all scenarios. Now, specifically with regards to having a lower back injury, you have to understand what the chiropractor can do. More importantly, you have to appreciate that the chiropractor understands what they can do and what they can't do. And the same could be said for all manner of professions helping you guys with your lower back pain, from the massage therapist to the Chinese acupuncture person to whatever, right? Your osteopath. They need to understand that you need to understand that they understand the constraints, because some people reach a little bit in terms of what they can and can't do. And that can be a little bit disingenuous sometimes, right? So bear that in mind, right? And we had someone on the podcast the other week being a bit disparaging to chiropractors, and I think unfairly so. There are good and bad in all professions, mine and others, right? So bear that in mind. But if we take the example, the typical example of a chiropractor who's doing manipulation-based work, so joint adjustments, well, what do they do? What they can't do is they can't heal your L5-S1 disc, right? They can't heal the L5-S1 disc. What they can do is work up the spine to make sure that these joints are working as helpful as well as possible. Mobilizing the neck, the middle back, whatever, upper lumbar spine. They can make sure your hips are going as well as possible. They can do some work on the musculature around this region to help make sure things are as good as possible around the area, so the lower back has a better time on a daily basis, taking strain off, so to speak. If your colleague is not feeling so good in the office, and you know they're not feeling so good, what do the other, hopefully, team members do? They rally around them, they take some of the strain off so they can go and get better, right? It's the same thing in the lower back, to draw a simple analogy. So that's how the chiro, the osteo, the physio, the massage therapist, the acupuncturist can play their role. But if they're saying, I'm going to heal your lower back and I'm going to fix it like that in 3 sessions, they're not being honest with themselves, and they're certainly not being honest with you. Well, they might be being honest with you because they've convinced themselves that they can do things that they can't, or they really just don't understand the problem, and well, that's another problem in of itself. Amelia Moore says, nothing but laying down, nothing but laying down doesn't cease the spasms. If we're in a pretty tough position, it can be difficult. It can be difficult. It really can. But we've got to start, right? If we're doing things, this is an important thing for those of you that are a bit more vulnerable. You're having a bit of a harder time with this. You've unfortunately gotten to a position where you are not a resilient person, physically, I'm speaking. And it might be testing you mentally as well, often is. If you're just going through life every day and aggravating your back just through the simple actions of existing on the planet, well, hey, you may as well do some rehab and do something that's actually going to reward you sooner or later. Because at the moment, you're going through 7 days of the week and you're aggravating yourself every single day and you get nothing out of it. At least starting the rehab in that scenario, you can actually start to make some improvement. Even if it's just observing that you've made improvement on the video and it hasn't translated to actually feeling better yet, right? Just seeing the improvement that you are demonstrating in your ability to perform these movements of rehabilitation helps you start getting closer to the goal. For example, right, if you were unemployed and had no money in your bank account, getting a job tomorrow afternoon does not get money in your bank account, but it's a step in the right direction. You then need to work for the week, fortnight, month, and then you get that payment in your bank account, and then you get the reward, right? A month later. Right? Just taking that first step of doing the right things and making some progress, showing up to work, doesn't solve the immediate pain of the fact that you can't buy anything because the bank balance is 0 and you don't even have a job. It's the same thing with the lower back. Some of you, your bank balance is in the negative, right? And you're going to have to put some work in before you get to a point where you're like, oh, this is paying off. And one of the things to motivate you in those moments is seeing the videos that you take of yourself when doing your rehabilitation and seeing the technique improve. Realizing that if all you can do for a squat is this, and all you can do for a hip hinge is this, that's not enough. But seeing that your squat used to, you have to hold on to someone's hands to do this, and now you can do it on your own, that's improvement. It's visible. It shows you, right? Kyle, I would suggest doing some of the things that we're talking about, right? Do the rehabilitation work. Do something that actually, you've got to ask the question, right? We're talking about possibly a nerve ablation for the lower back, right? Again, to deal with the pain, not to deal with the problem. The problem is you've got an injury in your back. Burning the nerves away is not solving the problem. Ask the honest question. How precisely does this improve the strength, health, and resilience of my lumbar spine? Now, I'd be gobsmacked if they said, well, the strength, health, and resilience of your lumbar spine is not an issue. It quite clearly is, right? It quite clearly is, if we've been struggling, right? And so let's start doing something that's actually going to improve those parameters first. Decroy says, what's good for an L4-5 bulging disc? Starting building resilience back into that area, right? Your rehabilitation, let's just take the example of the squat, but we talk about the 6 exercises, the dead bug, marching bridge, squat, hip hinge, step up, the single leg hip hinge. And I'm going to wrap it up with this, guys. Hopefully it's helpful for you, right? How is that working? Well, to start with, it's a valid test to give you a baseline of your current level of competence as a human being performing a movement that you do every day anyway, irrespective of whether you're doing exercises for your back or not. You get up and down out of chairs, etc., etc. So you're getting a baseline. How competent am I as a human being to move my own body? The answer often is not very, right? We're not very good at the movement. And maybe we go too low, maybe we wobble the knees a little bit, maybe we're doing some things, we're just not coordinated. Maybe we have to think. I use the example again. When people upload their videos, they're like, okay, when they're starting, okay. And that's how it starts, right? It should be, go and do a squat, Mike. Yeah, sure. Boom, boom, done, right? And everything's tight. Everything's good. It takes time to get to that for some of you guys, right? It takes time. So don't beat yourself up, but be honest with where you're starting. Be honest with where you're starting. So that's the squat as a test. And then you keep practicing that so you get better at the movement. So you become confident, just the body weight squat, right? And then we need to start making it effective, because at the moment we've improved our coordination and hopefully we are now squatting when we do other movements like getting out of chairs in a way that's better. That lessens the strain on our L4-5 bulging disc on a daily basis. It makes us safe. It means we're less frequently aggravating this bulging disc down here, which is helpful for the recovery process. Then we build strength because we find the right level of difficulty of the squat to actually challenge ourselves, right? Because what I just did a moment ago was just technical. I was just learning the skill, like writing with my left hand. I'm learning, right? It's not physically draining. It might be mentally draining, but not physically draining. I'm not actually challenging the tissues. So then we challenge the tissues at the right level, the muscles we're talking about here. And now the muscles get stronger. They get more capable of doing what they could already do, or what they've learned how to do. And we start to protect this lower back further. And again, exactly the same. If we've got a grade 2 spondylolisthesis, Jennifer, this is exactly the same stuff, right? It's protecting that area. In one of the cases with Decroy, it's the L4-5 bulging disc. In Jennifer's case, it's the spondylolisthesis we've got down in the lower lumbar spine. And then we progress on and we build strength further. And now we're applying load to the spine in a more significant manner. So now the spine itself, including the region that's got the spondylolisthesis, including the region that's got the disc bulge, is actually getting stronger. That happens slowly over many months. You can see why if we don't allow us to get past the first couple of weeks, we're not going to actually ever give ourselves the opportunity to get the result from rehabilitation work. Just looking at this, Roy says, I started doing cat-cow exercise and I feel cramping in my abs and lower back. Why are you doing, why are we doing cat-cow? What's the purpose? To get my back moving more. Sure. Wiggle the injured joint. I don't, Roy, you've been on enough of these lives, right? Hey, you've been on enough of them. Saving Grace says, I do see improvement. Then I'll get a flare-up down the back for weeks or months due to the pain. They did all the treatments. I'm making a leap in assumptions for Saving Grace, right? But I'm assuming she's talking about they did treatments to me and I felt better. None of that is building resilience. So what happens, Saving Grace, is they manage to get you so that you are in a position where you actually feel good, because baseline level of healing is taking place here because it's happening every day, but you have not built strength and resilience. So you're just one wrong move away from re-injuring yourself, right? And yeah, if you haven't, and that's why the rehab is important, because it gives you an appreciation for how resilient your back is, because a lot of you guys feel like your back is made of glass. At the same time, you will be doing things every day that maybe demonstrate to the contrary and getting away with it. Sometimes you do, sometimes you don't. But having proper rehabilitation work that you are doing that is progressive, where the loads are going up over time. When we see members post in, they started out doing body weight and now they're doing 20 kilos on their squats and hip hinges. Now they're doing 30 kilos on their squats and hip hinges. Then I used the example earlier of one of the guys, 80 kilos on the squats and hip hinges, or hip hinges, not the squats in that particular scenario. Right? With all these different kinds of conditions, it is irrefutable. The person is building resilience. They could not, verifiably could not do that, anything like that at the start. And guess what? That load is going through the bulging disc. That load is going through the section that's had a microdiscectomy. That load is going through the spondylolisthesis. They've just learned to do it correctly, and their body is slowly, over a period of months, building resilience as a result of them doing the rehab. It doesn't happen on its own. The resilience building doesn't happen on its own. Healing takes place, right? Healing is trying to happen every day, but resilience building, strength building is different. And often your levels of activity, the other side of your back injury, are significantly less than what they were before your back injury. So if anything, the global resilience of you as a human being, in the muscles, in the joints, in the tendons, is lesser after the back injury, unless you explicitly go through the process of rebuilding the resilience, right? And you know, Saving Grace says exactly long-term rehab, you know, and that is the truth. But that can sometimes put people off and say, well, I've got to do this for the rest of my life. It's like, no, what do you mean? Like, are you going to continue to eat for the rest of your life? Are you going to continue to brush your teeth for the rest of your life? Are you going to get up every morning and get dressed for the rest of your life? Of course you're going to go to do these things. Literally what you're talking about is what could probably be for the average adult in terms of what you actually need to do long term. Maybe it's like 2-3 hours a week, which means that you're suggesting you're turning your nose up at 3 hours out of 168 hours every week of doing something to improve your health, well-being, resilience, avoid, massively reduce the risk of ever having any of these things happening again, or knee injuries or ankle. Like, why would we not do that? Why would we not do that? Very, very difficult one to swing when we break it down like that. So I'll leave it at that for today. A little bit of a lecture at the end, but hopefully for some of you guys, like even if it turns one of you guys and goes, huh, okay, that's cool, right? That's cool. Roy, it's not just about doing the core 5. You actually have to make progress with them. Okay. The core 5 are not about giving you relief. The core 5 are about making objective improvements in the strength and resilience of your spine. Check out the program. Seriously, check it out. I'll leave you guys with that. Hopefully it's helpful. Thank you to all of you guys that posted comments, questions. Those of you guys that are members, of course, get in the members area. We're there to help you every single day. Every single day. Upload your videos, your questions, share your successes, share your challenges, because every single one of you that has a challenge, there are others that have that. So many times people say, well, you haven't seen something like me. I've got a really complicated case. And then you go and see in the group, there's a bunch of people that have similar things to you, right? Similar sort of challenges. So we're there to help you. And guys, we will be back live again, I think on Wednesday this week. So thank you to all of you guys that came. Hopefully it's been helpful for you. Do please share these if you do find them helpful and you know someone else that's struggling. You know, we're going live a couple of times a week, 3 times a week, typically Monday, Wednesday, Friday. If it is helpful for you and you know someone else that will benefit, then please do share this with them. And thanks to all of you guys that came. See you next time.